everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. Welcome to our webinar titled The Role of Interoperability in Value-Based Payment, Perspective of the Office of the National Coordinator for Health Information Technology, or ONC. On the next slide, I'd like to mention a few logistical items. You'll be able to download a copy of today's presentation from the caqh.org website tomorrow. That information is not on there now, but it will be available tomorrow. In addition, a copy of the slides as well as the webinar recording will be emailed to all of you in the next few days. We will save time at the end of today's program to respond to your questions. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. On the next slide, you'll see that this webinar is part of our series on the topic of value-based payments. I would like to thank our speakers for joining us today. Our featured speaker is Kelly Cronin, who is the Director of Interoperability for Healthcare Transformation at ONC. In addition, we have as a speaker Aparna Higgins, who is the President of Ananya Health Solutions and is a consultant to CAQH Core. Thank you both for being here today. On the next slide, we have the agenda. And as you can see, we will start off with a CAQH Core presentation on our work on value-based payment with a focus on interoperability. Our webinar today will focus on interoperability. Hello? Hello? Hello, everyone. Forgive us for the technical difficulties we have just experienced. Hopefully you can hear me now. It would be helpful if you sent me in the chat function, let me know that you can hear me. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. And I'm going to walk through some of these introductory comments quickly so we can get on with our featured speakers. Logistical items for you to know are you will receive these slides as well as the recording in the next few days. And in addition, please feel free to ask questions throughout the webinar. And again, I really hope you can hear me now. Yay, I hear yeses, thank you. This is part of our series on value-based payments. I'd like to thank our two speakers for today's webinar. Our featured speaker is Kelly Cronin, who's the Director of Interoperability for Healthcare Transformation at ONC. In addition, we have as a speaker Aparna Higgins, who's the President of Ananya Health Solutions and is a consultant to CAQH Core. I'm not going to worry with the agenda, but we will go ahead and get started with the CAQH Core presentation. So I'd like to introduce our first presenter, Aparna Higgins, consultant to CAQH Core. Welcome, Aparna.
Thank you. If we could go to the next slide. So we just wanted to set the stage here for value-based payment and what the goals are, which is moving from what's generally been known as the triple aim to the quadruple aim, which is better care, better health, lower cost, as well as improving the work life of healthcare providers. I think it's wanted to just point out that value-based payment, even though we've been experimenting now for several years, is still relatively young, especially compared with our experience with CAQH. And when CAQH began to address fee-for-service administrative complexity in 2005, the fee-for-service system is quite mature. And despite that, stakeholders were growing so increasingly frustrated by the lack of progress in the transition from manual fee-for-service transactions to electronic. And what was learned was that collaboration was key in terms of addressing some of the challenges in the context of fee-for-service transactions. And similarly, going forward, collaboration will be key in the realm of value-based payment. As implementation progresses, for example, health plans and provider organizations are expected to become data and analytics partners. We already see a lot of that happening right now. But by collaborating to leverage their respective data strengths, these stakeholders, can really focus on identifying opportunities for improving care management, improving quality, and reducing cost. Operational enhancements, which will be needed, put more stakeholders on a good footing as potential data collaborators. And that, one of the areas for operational enhancements is really improving the reliability of data, as well as in interoperability, which can lay the foundation for improved communication. Next slide, please. This slide just kind of shows you, the level of adoption of value-based payment. This was a survey that HFMA did with 117 senior financial executives about their readiness in September 2017, and you can see kind of the different levels of readiness across the different stakeholders. Separately, the Healthcare Payment Learning and Action Network, it's not shown on this slide, is also measuring the nation's progress towards adoption of value-based payment models, and they found that where we are, at least last year when they did the study, I think it was roughly over 30% of payments were in these kinds of alternative models. Next slide. So CAQH's core expertise is in bringing healthcare stakeholders together to develop, agree upon, and adopt business rules that improve the exchange of electronic transactions. The same expertise, experience, and resources can be used to support the development of a sound operational system for VBP. So the CAQH Core released a report, and this report analyzes operational challenges that may slow or add cost to the implementation of value-based payment. Creating or participating in a value-based model requires an intensive amount of time and resources for all the stakeholders involved. The research identified the biggest barriers to success and found that the lack of consistent expectations created inefficient business transactions. The report details 5 potential opportunity areas for action, which, if addressed, would minimize industry variations and, if improved, would smooth VBP implementation. I think one of the overwhelming themes in this message is that, what's really critical to success across all these opportunity areas and VBP in general is industry collaboration. And without that, VBP models could continue to be plagued with opaque payment structures, decentralized data structures, and lack of uniformity and consistency across the models. Next slide. So if the industry is going to be successful in lowering healthcare expenditures while improving quality and bettering the health of patients, there needs to be a common foundation that supports evolving VBP models. This foundation should reduce administrative burden, improve the exchange of information, and enhance transparency among stakeholders. The CAQH Core research identified 5 potential opportunity areas for action, as I mentioned previously: data quality and standardization, interoperability, patient risk stratification, provider attribution, and quality measurement. Addressing these opportunities would result in a more uniform approach, which would streamline VBP operations for both health plans and providers without compromising the competitive value of VBP models or the care of the patient. Next slide. Again, some data from a study that HFMA conducted, and this graphic really shows the anticipated gaps in readiness in VBP and showcases that interoperability is really top of mind for executives who participated in this study. And what you see on this slide is the percentage gap is the difference between viewing an area as extremely important, in this case interoperability, relative to the view that the organization had about their capability, whether they were highly capable or extremely capable in the area. So as you can see, VBP will require new and complex process capabilities. It sort of behooves us to think about what is the impact and importance of interoperability on VBP. And we're certainly going to hear from Kelly, in a few minutes. I think data and information are important for success in value-based purchasing. Exchange of data among care providers and between providers and plans, is critical to managing patient care and population health. Importance of timely availability of data at the point of care is, something that everybody's emphasizing. But we recognize the challenges with interoperability remain. Next slide. So there are three types of interoperability challenges, which you see on the slide. One is process interoperability, which is common expectations for operational processes and workflows. Technical interoperability, ability to pass data from one information system to another while maintaining accuracy and validity. And semantic interoperability, which is agreement on shared meaning of data, which is vocabulary standards. Next slide. So relative to process interoperability, stakeholders engaging in VBP require new and complex process capabilities to deliver patient management information across the care continuum that needs to be accessible to all parties involved. These process changes may also require new arrangements, partners, workflows, and data collection. Furthermore, there needs to be new processes in place to share that data. For example, so much research has illustrated how important social determinants of health are in caring for a patient across the care continuum and how these factors need to be considered in a patient's care plan to effectively improve outcomes. But these patient-reported data fields can be even more difficult to report consistently and accurately. So we'll need new processes in place to collect these data consistently and efficiently before we can expect an HIU to accurately supply social determinants of health information on a patient. Next slide. So one of the most important aspects of interoperability is really around technical interoperability as it relates to VBP. And this pertains to interoperability not just within but across organizations. But as we all know, proprietary systems can make this exceptionally challenging. So promoting technical interoperability would involve encouraging the use of existing standards to allow the sharing of longitudinal patient-level data across organizations, which could really help develop our ability to better assess outcomes and move to an outcomes-based payment structure. Next slide, please. And the last thing I'll highlight is semantic interoperability. So we've discussed the processes used to exchange the data and the systems used to input and retrieve the data, but what about the data itself? Health plans and healthcare providers agree that there's a challenge of, too much data. When caring for populations, it's important to be able to access the right data at the right time at the point of care and extract actionable insights. But sometimes sifting through all these different data sources and types of data can create a lot of noise and make it challenging for both providers and payers. Furthermore, non-standardized data and data quality also pose challenges to VBP operations. So improving the accuracy, completeness, and timeliness of data and enabling easier access to high-quality data will certainly be a high priority area. One example of data standardization issue that came up throughout our primary and secondary research pertained to something fairly, what one would think of as fairly simple, which is missing or inaccurate provider identification, but really essential in these models. So, for example, should a provider send their health plan, who they're partnering with, a tax ID number, and in which case, what should it be their NPI? Should it be the group level NPI? Should it be the NPI for both the individual as well as the group? So these are all sort of key questions that need to be answered, but there are no real standard approaches to addressing those questions. Similarly, there were differences in ways in which, for example, the term admissions is defined, whether it refers to an inpatient stay only, could it include a trip to the emergency department and so forth. So there's a lot of variability in terms of how these data fields are defined and used. So without consistent identifiers and common terms, it can be difficult to measure timelines and the nature of care, which can lead to issues with reimbursement, quality measurement, and cost. And then I will turn it back to Jessica for the polling question.
Thank you so much, Aparna. I really appreciate your presentation and briefing our audience on what CAQH Core has been up to on value-based payments. So let's go ahead and launch the next poll. As you just heard, the various types of interoperability that was identified in our research as potential pain points to VBP success. So please let us know which of these types of interoperability are presenting issues for your organization, and you can also mark more than one if that is appropriate. So I will give that a few seconds, and then I will quickly share the results. Let's go ahead and share them now. It really seems like all of it is presenting challenges and is important, and that makes absolute sense based on what we have seen from talking to our stakeholders. So with that, I would like to welcome our featured speaker, Kelly Cronin, who is the Director of Interoperability for Healthcare Transformation at ONC. Kelly, thank you so much for joining us today.
Thanks, Jessica and Aparna. I'm happy to be with you all today. So if you advance to the next slide, I wanted to spend the next half hour or so giving you an overview of some HHS priorities, particularly as it pertains to health information interoperability and value-based payment, and then give you an overview of everything that we're doing, a lot of the things we're doing to advance interoperability, and share how that's working really across the administration through the My Healthy Data initiative, and also touch on some aspects of reducing provider burden that are related. Next slide. So HHS has 4 priorities that they're focused on right now. The one is value-based transformation of the U.S. healthcare system, which includes continuing with the testing and evaluation of new alternative payment models in Medicare and Medicaid. The second is combating the opioid crisis. Third is bringing down the high price of prescription drugs. And then the fourth is addressing the cost and availability of insurance, especially in the individual market. Next slide. And as it pertains to value-based care, is there a delay in the slides? Should I wait till we advance?
My apologies, Kelly, we lost audio for a second, but we're back.
Oh, we're back. Okay. Sorry, I hope I can backtrack if needed, but this is just trying to highlight the areas of emphasis now for value-based transformation in HHS. The first one is really around interoperability and trying to make sure that consumers have access and control over their health information, but also that it really can follow them through the care continuum. So it's available to clinicians and their care team or their caregivers when and where it's needed. Also to encourage transparency on performance and costs from providers and payers. And again, I just mentioned continuing with the portfolio of testing alternative payment models in Medicare and Medicaid that will incrementally drive value and quality throughout the system, and removing government burdens that impede value-based transformation. So these are regulatory, administrative, some do relate to the lack of interoperability, but we're taking a systematic look at that. Next slide. So just as a reminder, we've made a lot of progress over the last 10 years, and we've seen significant increases in the adoption of certified electronic health records among hospitals. So a majority of hospitals, 96%, have certified electronic health records. So the care experience is largely digitized on an inpatient level. And the next slide shows that we've also made similarly significant progress among physicians. So the next slide shows the physician adoption, which is roughly in the high 70s, a little bit higher for primary care, but and specialty care is just a little bit behind the national average. But generally, most physicians are using certified EHRs in their ambulatory-based practice. Next slide. But despite this, there really hasn't been enough similar progress in advancing interoperability, meaning we haven't seen sort of the seamless exchange of information from one setting to another or for various purposes increase with the same rate or acceleration as we've seen with just adoption of these point of care applications. So the emphasis now across the administration is really trying to advance access and interoperability of health data. And we're doing this through the My Healthy Data initiative. So this is being done across CMS and ONC, the Office of the National Coordinator for Health IT, which is where I sit, in the Secretary's office in HHS. This is throughout the VA, the DoD, it's administration-wide. The next slide. And we're doing this through new authorities as well. So we have a new law, the 21st Century Cures Act, that is giving ONC the ability to regulate the software industry and be more specific about expectations about open data and open application programming interfaces, or what we call APIs, and also to create more of like rules of the road to make sure everybody follows the same basic policies and standards needed to ensure trusted exchange across networks. So instead of having a lot of little silos in the healthcare system of information exchange, we want to create a network of networks to make sure everybody's following the same rules so that information can be exchanged more seamlessly. We're also using all the CMS levers and authorities to advance interoperability. I'll say a little bit more about that later. And the VA is taking definitive steps through an open API pledge for developers that are using mobile and web-based apps, both for veterans and for clinicians and partners that they may work with through delivering care to veterans outside of the VA system. And the VA has also signed a big contract with Cerner, an EHR company, to implement across the VA system a new EHR system over the next many years. And they have a lot of interoperability requirements built into that very large contract. Next slide. So the 21st Century Cures Act was really, in many ways, a reaction to all of the stakeholder feedback over the last many years around the lack of interoperability and the burden associated with delivering care and trying to coordinate care, and this transition to value-based payment that has been more painful in part due to the lack of interoperability. And also that there's been a significant investment in electronic health record adoption, and many providers and hospitals have taken this step to implement certified technology, but yet they still can't exchange it easily in many instances for the coordination of care when a patient transitions to the next setting or goes from primary care to a specialist. So all of that feedback was acted on by Congress. There's bipartisan support to pass the 21st Century Cures Act that gave us new authorities. Next slide. So we're now working closely with our other partners in HHS to implement new provisions of this law. One is strictly through our rulemaking, where we'll be setting new conditions of certifying and maintaining certification for health IT. So an example is that we'll be very specific about what it means to have a published application programming interface, an API, that allows for easy information to be easily accessed, exchanged, and used without special effort. So it has to be easy for a software developer to be able to read and write code, to be able to easily get the data out of an EHR. And then we're also looking at voluntary certification of health IT for pediatric providers, and we'll be trying to address how health information networks will voluntarily attest to the adoption of the same sort of rules of the road that I mentioned, a trusted exchange framework, meaning they're going to follow the same privacy and security rules and the same standards and all the details of what you need to agree on to get information across the whole system seamlessly. So that network-to-network exchange. Next slide. So APIs are often being thought of now as sort of a path to putting the patient at the center of their care and being more empowered to get information on demand when they need it. And again, a part of this will be through what we do in our rulemaking, how we defined what it means for an API to be able to access, exchange, and use information without special effort. And also, how do we make sure vendors can actually prove that they can do that? So not just require it in a regulation, but then how do you test for it? How can you actually show that what you're doing technically does make it easier and better? And one thing that's going to help a lot of the industry effort in this space is through the FAST Healthcare Interoperability Resource. It's a newish standard that is focusing on making implementation easier and allowing for content in an EHR or an application to be more easily accessed and shared. And it uses more modern internet technology. So it's not quite as cumbersome as some of the HL7 standards that have been widely used in the past and still are used widely today in healthcare. This move to FHIR, which is more of an API-mediated exchange, we think is going to be an important enabler of this general shift. And when you look at where FHIR, the work around FHIR is now in industry, it's already gone through 3 rounds of implementation through the standards development process. And there'll be a new version released this year based on all the experience that they've had in the field and these prior iterations. And it's already adopted by over half of EHR vendors, and that includes most of the leading health IT companies. And some of you may have tracked that Apple has announced that they've had partnerships with many health systems now to help get data out of their health systems' electronic health records into iPhones. And then in recent weeks, they've also made an important announcement that sort of shows the industry shift in this direction, where they are opening up the information and the applications they have through their own open API, so to allow other developers, other companies to come in and build products off of the Apple Health Kit. Next slide. So another important part of the 21st Century Cures is really making information blocking illegal, essentially. So we are working with our Office of Inspector General to figure out not only how do we specify the details around this policy through regulation, but also how do we enforce it in partnership with the Office of Inspector General. So it pertains to both technology vendors and providers. So if there is an effort to prevent or interfere with or make a deliberate effort to discourage exchange or the use of health information, then that will be considered information blocking, and it will be pursued. Then, if it's reported and it's pursued or found to be legitimately information blocking, then it'll be enforced through the Office of Inspector General. And CMS will also likely play a role in reinforcing this through their policies as well. So we've heard a lot of anecdotal report. There's also been some empirical research in this area to show that this is a real phenomena, that there are instances where both providers and technology vendors are information blocking. And this new policy will make it a more concrete and give us the ability to act on bad actors. Next slide. So the other important provision that I mentioned before is creating this sort of rules of the road to be able to make sure that information can be shared more seamlessly across the healthcare system. And so we're doing this through what's called a trusted exchange framework and a common agreement that will really detail all the rules and the standards and the policies that health information networks will have to follow if they want to become part of this network of networks and be able to seamlessly exchange. So the way that this was put forth in the 21st Century Cures Act was to really partner with stakeholders. So just as Aparna was saying, how important collaboration is, we've learned over the last decade or more that collaboration in the health IT community is just essential to get any progress done. There's so many legacy systems. There's a lot of complexity with standards. There's a lot of complexity with workflow. It's really essential for us to have a collaborative public-private approach to figuring this out and to setting methods and rules for trusted exchange through a collaborative mechanism. So we've already done a lot of outreach and had a lot of stakeholder engagement over the last year, and have released a draft that the public has reacted to. And next slide. But before I talk a little bit about the specifics around that, I just want to make sure that it's clear that we're trying to address a really complicated and expensive process right now, where there's so many different ways of connecting in the healthcare system for health information exchange, or really more on the clinical data side. So to get, within a medical community or within a given healthcare community, to get a summary record of care from a primary care office to a specialty office, or from one hospital to a nursing home, you can use many different solutions, or in some cases, there aren't any solutions in certain geographies or certain markets. But it becomes extremely complicated to be able to navigate all these different agreements and to sign different business associate agreements, and it's really not efficient, and it's not something that can really scale easily. Next slide. Next slide. So similarly, it's expensive. So if you have to maintain a lot of different interfaces for all these different points of connection, one for your medication history, one for your summary record exchange, one for your labs, one to get your images, it's really expensive for most health systems, and almost impossible for a smaller doctor's office to be able to navigate all of those different methods of exchange. So we are trying to address this complexity and create a more uniform set of rules of the road that will allow for seamless exchange across networks. Next slide. So how will this work? What will it look like? Well, we recognize it's not just about ONC drafting a document and handing it off to one or two organizations. There really has to be a coordinating mechanism that allows for all the key stakeholders to come together, including government. And we are going to be standing up and funding a recognized coordinating entity to take on that role. So they will provide oversight and governance over what we're going to call qualified health information networks. So qualified health information networks will have connectivity brokers or information brokers, and there'll be a limited number of them, and they will be able to they'll be able to search or find information on a given person, or it could even be a population over time, find out where all that clinical data resides in the health system, and then be able to retrieve it and share it back with the person who asked for it, the individual or the provider that asked for it. So there'll be health information networks that will be connected to qualified health information networks. So it's sort of the broker level service at the qualified level, and there's a defined number of those. And then a lot of health information networks will sit underneath or be connected to that one, what we're calling a QHIN. But the RCE, the Recognized Coordinating Entity, will be a governing group. So it'll be an organization that will finalize the common agreement. ONC and government set sort of the higher level parameters and principles through a trusted exchange framework. But the very detailed aspects, almost like what would be in a contract that a QHIN will have to sign, could be the equivalent of like a business associate agreement. All of those details will be set in the common agreement that the RCE will finalize and maintain. So it's a partnership between government and a coordinating entity, and then all the different networks that will participate in the agreement. Next slide. So this recognized coordinating entity will, as I mentioned, be sort of the governance body that will oversee all this. And it will be expected that they really try to work with all key stakeholders and also listen to their needs around new use cases. So, for example, we are going to start with a set of permitted purposes, which I'll talk about in a bit, but treatment, payment, and operations that is currently allowable under HIPAA will be part of those permitted uses. But if someone wants to move beyond that to look at a different application or a different way of sharing information that's beyond the initial use cases, then they're going to have to respond to that and figure out how do we set priorities such that everybody participating in the common agreement can meet the technical capabilities and implementation necessary to meet that new use case. So they'll be sort of the arbitrator and coordinator of how do we grow over time, and how can everybody, work together to sort of build out these capabilities over time. Next slide. So we'll be releasing a funding opportunity announcement and planning to award a single multi-year award, a grant award, we're calling a cooperative agreement, to an organization in the private sector, a nonprofit organization that will be able to serve this function as being sort of the coordinating entity. So they will be, as I mentioned, working with ONC to really create and maintain this common agreement, but also to oversee the qualified health information networks that will be responsible for routing information across all the networks in the country. So this regional coordinating entity, or the recognized coordinating entity, will have oversight, enforcement, and governance responsibilities of these qualified networks. Next slide. So in essence, another way to look at this is that it's creating both a technical and governance infrastructure that will connect all health information networks that are underneath a set of qualified HINS. So there'll be a certain defined number of qualified health information networks to just simplify the exchange in the country, because we couldn't have 1 million or 1,000 of them. It would be too complicated. We'll have a defined, discrete number of qualified networks that will make sure that the queries or the searches for all the information are limited to a defined number of entities that can really perform that function. But then underneath those, or the tethered to those qualified networks, will be a lot of different other health information networks. It could be, for example, all the regional health information exchanges that are in many places in the country. Next slide. So there's also going to be, we anticipate, a lot of different participants. There'll be payers, there'll be public health organizations and agencies that will want to be participants either through a health information network or connected through a qualified network. There'll be federal agencies that will want to be exchanging information. Individuals, there'll be an important priority use case to make sure that individuals can obtain access to their longitudinal health record. And for providers, clearly, there'll be early participants. Next slide. So we think that it's going to be really important for providers to be able to enhance their care coordination and care management. And clearly this is important for the transition to value-based payment. But it's really going to be intended over time to simplify the experience for providers. Right now, it's not only, all the different interfaces they're maintaining, but it's also the complexity of having to sign into different portals to incorporate information, and not being able to, do that easily in their workflow can be very cumbersome. So this is intended to make it easier for providers over time. We also think it's going to be important to allow for the aggregation of data. And there's, as I mentioned before, that FHIR standard. There's a resource that's being developed that will allow for population-based data to be accessed. So it could be searched and aggregated and then shared with other organizations. So that will take a little bit more time to implement, but it's a really important evolution, we think, to be able to allow for data on a population to be shared with a clinical data registry or a data analytics company, so they have more visibility into the patterns of care, or they can calculate quality and performance more readily. Next slide. So I think I mentioned some of the benefits of, next slide. I think I already covered a lot of points in that one. And for caregivers and patients, we think it's going to be important for them to be able to not just get information from the primary care doctor's office or the hospital that they just went to, but to be able to query for information that is longitudinal, that represents their whole care experience, regardless of where they've received care. The access and being a node on the network of networks will allow them to be able to retrieve their complete medical history. Next slide. So another important concept that's part of the work that we're doing, and very much tied to this trusted exchange framework and the network of networks, is the U.S. core data for interoperability. Next slide. Essentially what we're trying to do is build on what we've already been standardizing as an industry for many years now, and the common core clinical data set that has been specified in previous regulations by ONC and CMS. So things like patient name, date of birth, race, smoking status, problem list, labs, medications, allergies, care team members, all of that is going to be in a first version of U.S. core data for interoperability, and it'll be expected that all health IT vendors can have this structured data available in their applications, so that when it comes time to sharing, all this information should be readily available in every application. That will then make it easier for health information networks to have that information available as it gets routed across the system. But this will grow over time. So next slide. explains how we're going to try to take a systematic approach to expand the core data set. So think about candidate data classes and emerging data classes. One example that Aparna mentioned that we're very mindful of is the importance of social determinants of health. But a lot of that information isn't widely standardized and systematically captured by healthcare providers. There are some standards developing, some are available for different types of data that are social determinants, but right now we're considering that under the emerging data class. So in order to have a systematic approach where everybody, providers, health IT vendors, the network services, it can all be expected to adopt and share this information. We want to have sort of a rules of, or a trajectory in which we're all going to follow this path together. So we know by date certain, we're going to have this information in certified products. And by date certain, it should be exchanged on the network of networks. So this way of categorizing an initial version 1 of a core data set and then have candidate data classes and emerging data classes will allow us to have a more systematic approach where everyone's going to be sort of following the same path and timeline. Next slide. So this sort of shows how we are proposing for it to work, and we've gotten a lot of public input on this from a task force with our Federal Advisory Committee. So we expect that candidate data elements could move up to be part of the U.S. core data for interoperability in 2019. And again, the next year in 2020, we'd have maybe 4 new candidate classes. So how fast we go and what goes into all of those elements and classes, we'll be talking a lot about in the years to come. But there's a lot of people that want to see this move as fast as possible because the needs are significant, and things like advanced directives or certain social determinants. There's some very important categories to different stakeholders that may, in some cases, end up accelerating the timeline for them. Next slide. So we also have seen, I think, a lot of actions out of CMS, and just to touch on a few, there's already been an overhaul of what we've usually called meaningful use, the EHR incentives program, and it was renamed Advancing Care Information under the MIPS, or the Quality Payment Program. But there's really a strong emphasis on interoperability and flexibility, trying to reduce the burden on providers as we've been sort of revamping what that looks like. However, we're holding firm on the requirement to use 2015 edition certified EHR technology, which includes the requirement for open APIs. The other thing that has been in recent CMS proposed regulations is to get input on how CMS could require health information exchange as a condition of participation in Medicare, meaning to get any payment at all from Medicare, hospitals could potentially need to share an electronic summary of a discharge summary or a summary record of care when they are transferred or discharged to another healthcare provider. So that's an existing requirement in the conditions of participation for hospitals for Medicare, but it could be modified to suggest that they have to do that electronically. They have to electronically exchange a summary record of care at the time of a hospital discharge. That would be potentially something that could be phased in over a number of years, but they are seeking input on making that change through regulation. They've also released the next version of Blue Button. This is a way for, under Medicare fee-for-service, for beneficiaries to get access to their health information available from claims. And they've made it a lot more friendly for technology developers to access this information through an open API and a FHIR server. Next application. In fact, I think my numbers are dated there. I think there's actually several hundred developers that are working on this now, and many are in a implementation mode or pilot mode. Next slide, please. So a little more specifics about the inpatient prospective payment system proposed rule. This is what initially redefined the EHR incentives program and is now calling it the Promoting Interoperability program. It's really focused on measures that require interoperability and sharing health data with patients. It reduces the overall number of measures, and it also modified them to reduce the burden on providers. It's also improved the alignment between hospitals and physicians or eligible professionals under MIPS. And the EHR reporting period is going to be 90 days as opposed to 1 year in both 2019 and 20. I think I already mentioned it requires 2015 edition of certified technology. That's the most recent edition we require under regulation, ONC regulation. And then it's made the scoring methodology different in that it's removing an all or none approach. It's based on 6 measures across different performance categories. And it's also made the security risk analysis just an upfront requirement. So you have to do it, but you're not going to be scored on it. Next slide. So just a little bit about Blue Button, because this has gone through a lot of modernization. And it's sort of a good example of how you can sort of apply this sort of a new approach, the FHIR standard, to make data more readily available for developers and beneficiaries. So there's claims data for 53 million Medicare beneficiaries that are accessed through this chronic care warehouse. And this FHIR server sits on top of it and allows for developers to easily access the data on patients that they are serving. Next slide. So a more, I could say, current example of what we are doing with industry now, and in particular with payers to promote interoperability and reduce burden are 2 complementary, I would say, collaborative efforts. One is an ONC payer to provider task force, and the other is called the Da Vinci Project. But they're both relying on health plans and health IT experts, standards experts, to get together to really accelerate the adoption of FHIR in industry. And doing this really to support, in many instances, value-based care exchange, or to support value-based care. So one example is, prior authorization. I think, as everyone knows, it can be very cumbersome. While there are standards to support it, there's a lot of health plans that vary their rules around, what needs prior authorization, what's required for prior authorization. But even just to know whether prior authorization is required for a given insurance company, that could be better understood at the point of care. It's also going to be important to improve provider-to-provider interoperability, so sending orders and plans of care and other specific aspects of medical records. So essentially, the piloting and scaling of FHIR for these different kinds of priority use cases is going to be advanced through both of these efforts. The Da Vinci Project is working more specifically on use cases and getting the FHIR resources set, and then the payer to provider task force is thinking more along the lines of what do you need to do to scale this, and sort of what are the highways that we need. So it's sort of a bigger infrastructure level effort. Next slide. And so just to explain this a little more clearly, perhaps, the Da Vinci project will create implementation guides based on fire standards and actual sample code. So the the pilots will be able to use that code and actually demonstrate that it can work. So they're prioritizing document requirements discovery and 30-day medication reconciliation as two use cases that they would like to, I think, develop implementation guides on later this summer and then pilot. The ONC P2 task force is really focusing more on the architecture for exchange with fire. So things like identity authentication messaging and creating a clearinghouse for these fire-based solutions is really their area of focus. So some examples would be a directory or resource locator for fire endpoints, or they'll allow for testing or conformance and certification to make sure these things can actually work when you're starting to implement at scale. So these efforts are complementary, but they're showing, I think, how we're working with both technical experts and a lot of different people in the payer community to make some specific progress. Next slide. So what's next? More policy changes to advance interoperability. I think you'll see a lot more through both ONC and CMS rulemaking and guidance in the next year, even in the coming months. There'll be a recognized coordinating entity that'll be funded, and they'll be governing health information networks. The Trusted Exchange Framework and the Common Agreement will be out in draft form for public comment the first quarter of 2019, and we'll also be releasing a draft report to Congress on reducing provider burden related to health IT. So I'm sorry that I think I talked a bit long. There may not be that many questions or time for questions, but I'm happy to stay on for as long as we can.
Thank you so much, Kelly. This was a great presentation, and also thank you for bearing with us as we had technical difficulties, which took away time from your presentation. So my apologies, Kelly, and thank you to our audience for hanging on with us. We are going to skip the next polling question and try to take a couple of questions from the audience. And because we are going to run out of time, if you do have questions, please submit them to us at core@caqh.org, and we will answer them directly. So let's take a couple of questions. The first one is for Kelly. Would the Trusted Exchange rules include HIPAA privacy and security requirements to ensure the protection of PHI or EPHI?
I think the short answer is yes. Both the Trusted Exchange Framework, there's two parts, Parts A and Parts B, will be focusing on what is necessary from a HIPAA perspective. So it'll reinforce all the HIPAA protections and policies, but it may even go beyond that to specify what that means in the context of a health information a qualified health information network. So yes is the short answer.
Thank you. And the next question is similar. I think when that slide when you were talking about APIs and the Apple, I got a lot of people asking questions. So this next question is a bit similar, and it's how does the API and the data sharing follow the HIPAA standards? There were several questions along that line.
Yeah, well, I think if Apple is working with a health system that's a covered entity, then they need to be, operating as any health IT vendor, as a business associate would, if they're retrieving information or accessing information from the covered entity. So I think all of the parameters of treatment payment operations still apply, or when is consent needed, when is disclosure appropriate. All of that is still very much applicable to what Apple is doing, particularly in partnership with the health systems.
That makes sense. And thank you so much for clarifying that. We received quite a bit of questions about that, and I think your answer probably clarified a lot of our audience members. So again, if you do have additional questions, please send them to us and we will respond directly. And thank you so much to our speakers and to our audience for joining us today. The slide 52, which you will receive in the next day or so, includes all the information about our webinar series in case you want to listen to that. Thank you so much for joining us. Have a great afternoon.